Hello, friends. So I'll be talking on this series 10 myths about albumin. So, as you're aware, there are these series which are coming in intensive care medicine. So this was something which came in intensive care medicine in 2022. So I had done my first talk on albumin in CLD. So this is an extension of it which we can look at. So the first myth is albumin leaks from the intravascular space into interstitial compartment and contributes to edema. So that doesn't happen. So that is false. So it does not. So basically, when you look at this pictorial representation of this is the vascular lumen. So vascular endothelium is lined by this endothelial glycocalyx layer, and there is interstitium. So the presence of albumin is what influences the oncotic pressure within the vascular lumen. So this albumin, presence of this albumin basically prevents the extravasation of the fluid. So when there is a low albumin, so this oncotic pressure comes down. So then there is extravasation of this into the interstitial space is what typically happens. So the movement of albumin to interstitial space typically can happen when this oncotic pressure is very low. And this is determined by what is called as transcapillary escape rate. And this leads to the distribution half-life will be around 15 hours. And this transcapillary escape sort of a rate happens at 5% per hour. So this is the sort of albumin that can escape into the, so which means there is not significant amount of albumin that gets extravasated into the interstitium. It happens at a very small rate only when oncotic pressure is very low, and it is 5% per hour is the rate. And this rate increases when there is a sort of inflammatory process which damages the vascular endothelium. So it can happen in the presence of severe sepsis or inflammation or vascular endothelial injury or in a post-surgical setting. So these are the settings in which this transcapillary escape rate can increase, and the leakage of more albumin into the interstitial space is something that can happen. And also we need to understand, once the albumin leaks into the interstitium, there is a lot of drainage of this albumin through the lymphatics back into the vascular lumen. So that's why even though the albumin leaks into the interstitial space, it does not get retained in this because the lymphatic system tends to drain this albumin back into the vascular lumen. So that's why it's a myth that albumin leaks into the interstitial space and remains in the interstitial. The first thing is the leakage is very minimal. Even if it leaks, the lymphatics send it back into the vascular lumen. So that is the first myth. And also another important aspect in this is the vascular sort of a endothelium or the vascular capillary layer that is there. So this is more vulnerable to the albumin leakage because the endothelial, it is not the leakage of albumin into the alveolar space or into the interstitial space happens much more easily with the breach of the endothelial glycocalyx layer, and the leakage not necessarily is always dependent on the endothelial glycocalyx layer because the lymphatics play a bigger role in the vascular endothelium, and there is 7-fold increase in the vascular drainage from the circulation into the interstitium in the pulmonary vascular bed. So the lymphatics play a bigger role in trying to cause extravasation of the albumin and the other components into the interstitial space in the pulmonary vascular bed. So that is something which we need to bear in mind. So the myth 2 is albumin is less effective for intravascular volume expansion than artificial colloids. So this is false because albumin is more effective than colloids. So that is something which we need to bear in mind. So albumin is more effective than colloids in resuming the intravascular volume status. And this was shown in the SAFE study. So in SAFE study, as many of the listeners would be aware, this is a landmark study. It came from Australia. They compared 4% hydroxy human albumin solution with 0.9% saline, and they saw the ratio of the fluid to compensate for this human albumin was 1:1.4. And they compared with colloids, and in colloids it was 1:1.2, which means to say albumin is more potent. So you need less amount of albumin to restore the intravascular volume status as compared to the crystalloids or colloids. So it is 1:1.4 or 1:1.2 for colloids. So the myth 3 is albumin administration prevents acute kidney injury. So there are certain things which I learned when I was reading this paper. So this is yes, actually, because this something which possibly many intensivists earlier did not believe, that albumin administration prevents acute kidney injury. It does prevent in specific settings, which we had covered in the previous lecture. It prevents acute kidney injury in CLD, that we are aware, because in hepatorenal syndrome, albumin has a role in preventing worsening of acute kidney injury. So in CLD, acute kidney injury carries poor prognosis, and recurrent acute kidney injury can cause chronic kidney disease. And albumin has shown to help in the reversal of this acute kidney injury. And it has shown in post cardiac surgery also, albumin has a bearing on preventing acute kidney injury. So this was the study that we did deliberate when we spoke about CLD, that albumin with terlipressin, when compared with albumin and noradrenaline, albumin with terlipressin was superior in preventing acute kidney injury. And the dosage that was used is 1 gram per kg on day 1, followed by 20 to 40 grams per day. This is in CLD, where albumin is used to prevent progression of acute kidney injury. So that is the third thing. So the third myth is albumin prevents acute kidney injury. Yes, we said yes in specific. So the Albios trial, this came from Italy. So in Albios trial, however, it did not show benefit. So this trial was done in patients with severe sepsis and septic shock with hypoalbuminemia. And here they compared human albumin solutions 20% compared with standard. Here they did not show any difference with AKI or the need for renal replacement therapy when albumin was used. So what we saw is albumin is helpful in preventing acute kidney injury in specific setting, which is CLD and maybe in post cardiac, but in sepsis and septic shock, which we intensivists deal with, this Albios trial is a reference. We did not show any difference. So in our ICU settings, in sepsis and septic shock, it does not hold promise. But having said that, human albumin solution did not have adverse events on renal function tests. So that is something which we need to keep. So myth 4 is albumin improves survival in sepsis. So here again, as intensivists, we need to bear in mind, there is some pointers towards that, maybe, but it is still not very sure. It is uncertain. So again, we need to go back to SAFE study. So in SAFE study, as you know, they took all ICU patients and compared 4% human albumin solutions, and they compared with crystalloids, which is 0.9% saline. And here, when they took the subgroup analysis of only sepsis, they showed reduced mortality, but that was not statistically significant. There was signal towards reducing mortality, but it did not attain statistical significance, because in the SAFE study, when they did a subgroup analysis of 1,218 patients with sepsis, 603 in the albumin group, which got 4% human albumin, and compared to 615 patients who got saline, if you see, mortality was 30.7 in albumin, 35.3. And as you see, it did not attain statistical significance. You see the confidence interval, it did not attain. But there was a signal towards pointing towards possible benefit if you take a bigger number, that albumin may reduce the mortality. And Albios trial, which was specifically done in sepsis and septic shock, when they took sepsis and septic shock together, it did not show any difference in mortality. But again, they did subgroup analysis only with septic shock, only patients with hypotension, and they compared 20% human albumin solution with standard. Here they found reduction in mortality. And if you see the confidence interval, it just about attains statistical significance, where you have a relative risk of 0.87, 0.7. So it became significant when they took only septic shock. But when they combined sepsis and septic shock, it did not attain statistical significance. So that's why we could say that in sepsis, we are still not sure whether it does save patients, but there are signals, because in the SAFE study and Albios study, there are signals that it may help. So when we read this paper, again, there is resurgence of albumin now, because albumin was something as intensivists we had shunned it. But now looking very closely on the recent developments, there are certain signals evolving, more so based on our understanding of the endothelial glycocalyx layer. So myth 4, albumin improves survival. Yes, we said it is. So this was a RASP study, which again came in. This study was done in oncology patients. This came from Brazilian group in 2019. They took 360 patients, oncology patients. And here they compared human albumin solution 4% with ringer lactate. Again, here 7 days and 28 days survival, there was no difference in sepsis. So you saw SAFE study, there was signal, no statistical significance. Albios trial in septic shock, it attained just about statistical significance. RASP study in oncology patients, no difference with mortality. And FRISK study, we did talk in the last talk in CLD. FRISK study was done in CLD patients with these fluid resuscitations in septic CLDs. So here 304 patients were compared 5% human albumin with 0.9% saline. It was shown that it improved hemodynamic status. So reversal of hypotension in 3 hours occurred better with albumin solutions as compared to the saline. And it improved heart rate, lactate clearance, tissue perfusions, and early survival. So this was an Indian study, Frisch study in CLD patients. So in CLD, it may definitely we understand that it has some benefit, but in other groups, oncology patients and the SAFE study showed in sepsis, there were some signals, but did not attain statistical significance. So the myth 5, albumin improves the effect of diuretics. So this is also interesting for our intensivists. So yes, it does improve the effects of diuresis, but only temporarily. So what has been shown is when there is hypoalbuminemia, they become resistant to diuretic action because the diuretics bind to the albumin for its effectiveness. So it is shown that albumin has to bind to the loop diuretics for its effective action against this diuretic sites for its effective function. But when albumin is low, so the effectiveness of loop diuretics comes down. So there was this study which came in US. They did in 40 mechanically ventilated patients who had acute lung injury with hypoalbuminemia. Here they used albumin with IV furosemide. And they showed that it improved oxygenation and improved hemodynamic stability. And there was increase in the net negative fluid balance, which means there was more effective diuresis and they could attain net negative balance better. So here they used albumin with furosemide because there was hypoalbuminemia. So this was a meta-analysis which came from the Taiwan group. This came in 2021. So they took 13 randomized controlled trials which used albumin with IV furosemide. And here they showed it increases the diuresis by 31.5 ml per hour. And it improves the sodium level also by 1.76 milliequivalents per hour as compared to the group we did not get albumin and furosemide. And this effect was more pronounced when serum albumin was less than 2.5 grams per deciliter. And the effect was more pronounced in 12 hours. After that, the effect wanes off. So it is a temporary effect. So the answer is yes. So in the situation where you have a very deconditioned patient with hypoalbuminemia, with a fluid overload, just giving furosemide may not be as effective as when furosemide is given with albumin based on these two studies is what we can tell you. This is something useful for intensivists because we had shunned albumin completely. So this is something which we could keep in mind. So this is also interesting for intensivists. Albumin administration improves fluid removal during renal replacement therapy. So this is something I'm sure many of intensivists would be aware that many nephrologists tend to use albumin while doing dialysis, and possibly as intensivists we were not very comfortable with that practice. But maybe now we have to revisit our thoughts because there is some evidence for that. Yes, it does. Because in dialysis, it is shown that when there is a hypotension that happens, because in intensive care, we often see that someone is on dialysis, they do develop hypotension. When they develop hypotension, there is a limitation of the effective fluid removal that can happen. And it does increase the duration of patients being in fluid overload for a longer time. So this was a very good study that came in 2021, actually by US group, where they took 65 patients with acute kidney injury, CKD, and they looked at 249 sessions. So here they compared the group which got human albumin solutions 25% and the group which got 0.9% saline. And they found the hypotension was significantly less in the group which got albumin as compared to the group which got saline, and that got 100 ml of albumin. So the hypotension was significantly less in the patients who got albumin as compared to the group who did not get albumin. And the fluid removal also was significantly better in patients who got albumin. It was 8.27 ml per kg per hour increase in the fluid removal. So the fluid removal was much better when albumin was used along with dialysis. And then they did a secondary analysis of this renal trial, which came again in 2021. Renal trial, they did a secondary analysis of 1,508 patients, and 51% of the patients in this group had got 4% or 20% human albumin solutions. And the patients who got 20% human albumin, there was increase in the net negative fluid balance. So this renal trial and this particular trial, which came in 2021, both sort of justify that if our intent is to prevent hypotension and if our intent is to enhance the fluid removal and reduce the hypotension, maybe we could consider albumin in patients who have hypoalbuminemia. And this has been a nephrology practice where we have not been comfortable, but now with these two new trials that have come, maybe we should possibly consider that yes, albumin may have some benefit in preventing hypotension and increasing the fluid removal in fluid overload status. So this is something which I learned when we were preparing for this talk. So the seventh myth is albumin decreases mortality in liver cirrhosis. So this we are pretty sure there are definitive indications for use of albumin. Yes, but only in specific. So we know established uses of albumin is large volume paracentesis and hepatorenal syndrome and SPP. So this we have covered in the last talk. So these are the three indications where it has good sort of justification. But there was this sort of practice where long-term usage of albumin was considered. So this was again a sort of a meta-analysis of 9 randomized controlled trials where they used human albumin solutions for more than 1 month versus standard in 1231, and they found there was reduction in mortality. But this was refuted or this was debunked by this latest study, which is the entire study which we discussed, 35 centers, 808 patients, where they give albumin once a day for 2 weeks to raise albumin more than 3.5 grams per deciliter. But in this study, there was no benefit in reducing complications or no benefit in 3-month survival and no benefit in increasing the adverse events. So entire study debunked the thought that long-term usage of albumin has any benefit in CLD patients. But the established indications remains only 3: large volume paracentesis, SBP, and AKI, hepatorenal syndrome. So that we are very clear. So eighth myth, albumin increases mortality in traumatic brain injury. So this again, there were pointers in SAFE study which showed maybe, but we are not sure because the SAFE study showed this trend. And the basic study, if you see the basic study, basically the basic study which came in 2021 showed is in traumatic brain injury, when you compared balanced solution with normal saline, which means hypotonic saline as compared to 0.9%, this has a lesser tonicity. The mortality was much higher, as you see, 31.3 versus 21.2, and that attained statistical significance. And the SAFE study, when they did a subgroup analysis of 492 patients with traumatic brain injury, 241 in albumin and 251, mortality was more in the albumin. So this was very clear, and we did deliberate during this. But then there were criticisms for the SAFE study because the osmolality, because in SAFE study they used 4% albumin, the osmolality of the albumin was low, 266 to 267 milliosmolar. So basically, our whole understanding is in traumatic brain injury, we all understand using hypotonic solutions worsens the ICP and worsens the outcome, and that's what was shown in traumatic brain in basics trial, and that's what was shown in SAFE trial, where the osmolality of the albumin that was used was lower. So we cannot use any hypotonic solution in traumatic brain injury because that increases ICP, worsens the brain edema, and worsens the outcome. So to disprove that, Australians did an animal study. So they did this study in the sheep, and they compared, they used two hypertonic, they used human albumin solutions, hypotonic and isotonic, and they found the ICP increased by 8.5 millimeter mercury when they used hypotonic human albumin, like what they used in SAFE study. But the ICP did not go up significantly where the isotonic osmolality, isotonic osmolar human albumin solution was used. So again, goes on to show it's the osmolarity of albumin that is important and not albumin per se. So ninth myth is albumin substitution to correct hypoalbuminemia from all causes reduces mortality, which means just correcting the number, would it reduce mortality? We are all very sure as intensivists that we don't use albumin to correct numbers. No, it does not. So just because there is hypoalbuminemia, we should not give albumin. Again, SAFE study showed when they took all critically ill patients where they used 4% human albumin and compared to 0.9%, there was no mortality difference. And Albios trial, they took all sepsis and septic shock with hypoalbuminemia, and they did not show any difference in 28-day mortality or 90-day mortality. So the last myth, albumin administration increases sodium chloride load. Whether it increases the sodium and chloride, probably it does increase, but it is not relevant is what they've shown. So when they use human albumin solutions at 4% and 5%, it does increase sodium and chloride. But what has been shown is when you use 20% human albumin, there is less chloride increase. So that is something as intensivists we need to bear, because the albumin which we commonly use is 20%. So 20% has less chloride and it causes less chloride increase. And this was shown in LICRA trial. So LICRA trial again came in intensive care by Australian group, where they compared 4% human albumin and 20% in post cardiac surgery patients. And they found that the 20% human albumin, when they used, they had less chloride increase. And this did not have any bearing on renal, because we understand increase in chloride has a bad effect on the renal effects. So in this particular trial, 20% when they used, that group did not have any renal adverse effects, and there was less chloride increase when they used 20%, and none of them had any adverse renal effects in either of the groups. So that is something which is important. So although it does increase little bit, but that does not have any deleterious effect is what we could conclude. So that's about the 10 myths, so that we could gain clarity on the role of albumin in today. So I think as intensivists, the thing we can subscribe with, there is a evolving evidence now. There seems to be a resurgence of possible role of albumin. Maybe in sepsis, septic shock, we may need bigger trials. It may have effect. But for me, the learning point was in the CKD, where it does seem to have some promise, especially patients who are on dialysis. Use of albumin reduces the hypotension and it does improve the fluid removal. And as for intensivists, in a situation where there is low albumin state with fluid overload, when we are using furosemide, adding albumin increases its potency and its effect in attaining fluid balance and better diuretic effect. So these are two distinctly new things. And in sepsis, septic shock, there is an evolving evidence, because if you see Albios trial, only when they took septic shock, there was mortality benefit. So these are something new, and it does increase chloride, but not an effect that it would cause any harm. So thank you very much. So I end with this beautiful quote: knowing your own mind is a solution to all our problems. So thank you one and all.